Hello, my name is April Norris, and I am a nurse and an FNP student at Auburn University. I will be doing a head-to-toe assessment. I will start by saying that before I came in, I would have gathered the history on my patient, and then when I entered the room, I would wash my hands, introduce myself to the patient, let them know that I'll be caring for them, and as I do all of this, I would be getting a general overview of inspection of the patient, the demeanor, attitude, all of those kind of things that would go into my objective data. Would also get vital signs, blood pressure, temp, respiratory rate, O2 sat, and pain score, go through all of my subjective portion of my assessment, and then go into my physical assessment. I would begin by looking at the patient and inspecting the skin just from what I see. I do not see any asymmetry. I would start at the head. Inspection complete, I would go on to palpation and palpate the hair, any kind of abnormalities, any bulges, abrasions, any sort of skin moles or anything. Also, the consistency of the hair and where it may be. From there, I would come down and I would palpate the temporomandibular joint, asking the patient to open their mouth and feeling for any kind of crepitance or clicks or close. Any pain with that? Okay. And then I would move on to the face. I've already looked at it while I was talking to them and seeing all of the kind of motions that they can make while they smile and they talk with me. Next, I'm going on to the sinuses. I'm going to palpate the maxillary sinus and the frontal sinus, any tenderness there. Next, I will be moving on to the eyes. I'm going to inspect the outer eye, looking at the eyebrows, the eyelid, seeing the curvature, the shape, making sure that there's no redness, no drainage. I'm going to inspect the sclera, also looking at the pupils, which look like they're about a 3, and the cornea, see if there's any kind of abrasions, and pupillary, and the iris, excuse me. I'm also going to look for the lacrimal duct, make sure that it is patent, and it is. Next, I would be going on to the inner eye. I would get my ophthalmic scope and turn it on. I would ask my patient if they could just look forward. I'm going to be coming in with their right eye. I'm going to be looking with my right eye in, and I am, oh, there's the red reflex, and I am going to turn my dial until I'm able to visualize the optic disc. Almost there. There we go. And any kind of vessels. Make sure that there's no constriction of the vessels. Also, the macula and the fovea corpalis, I believe, is what it is called back there, making sure that there is no kind of abnormalities or anything like that. I am next going to move on to the ears. I'm going to inspect the outside of it, and of course with anything that I am doing, if I'm going to be doing it on one side, I'm going to do it with the other. For time constraint, I'm going to do one side and then verbalize that I would do it. So as I go to the ear, I'm going to inspect the outside, the auricle, and then palpate, see if there's any nodules, any tenderness, slight shaking, make sure that there's no otitis externa, and then I am going to gently insert the otoscope. I am going to look. There's the temporal membrane, or the tympanic membrane. It is kind of a gray, shiny. I am looking for bone in there. The name has escaped me, but as I look, I'm also making sure that there is a patent canal, and that there is no redness or inflammation with that. And of course, I would go and do the other ear as well. While I am here with my light, this is when I would also go on to my nasal exam. I would simply place my head here and gently bring back the patient's head. I'm going to use my light to look up into both nares and find the turbinates, make sure that there is no inflammation, that they are pink and moist. There's a slight drainage. I'm also going to look at the septum of my nose. This one is kind of deviated partially to the left, and so that would be something to give education and to have further discussion with the patient about. While I am also here, if there was any kind of sinus pressure, I could also use my lights to illuminate the sinuses while I was there. While I am still here in the face, I am going to assess my hearing with the Weber and Rhine sign. Let me know if you hear one or both ears.
Both.
All right. Next thing I'm going to do is the Rhine. I'm going to place my tuning fork back here. Let me know when you stop hearing it.
Okay.
And when you stop hearing it.
Okay.
And longer with the air conduction rather than the bone conduction, which is a normal finding for ears. Now that I am done with that, I am going to come down to the lips and the mouth, and I am going to first inspect once again the lips, see if they are moist, if there's any cracks or anything like that. I have noticed on him they are maybe a little chapped. It is winter and it is a little cold, so I may have a discussion with him about that and keeping moisturizing gel on his lips. I would ask, I'd like to see in your mouth, please. To open, I'm going to look at the roof of the mouth, the buccal mucosa, and all underneath of the tongue. Any kind of ulcerations or pain. I would ask the patient to smile. Looking at the teeth, at the gums, any pain, any bleeding that you've noticed. These are all things that you're going to assess as you are going through. While we are here, we can talk also about the cranial nerves. We can assess cranial nerve 1 through smell. Ask the patient to close their eyes. Tell me what you smell.
Lavender.
Mm-hmm. And then with cranial nerve number 3, 4, and 6, you can open your eyes, thank you. You can ask your patient to simply follow the tracking. Just watch my thing. I'm going to go in all visual fields. Make sure that there is smooth eye movements, that there's no nystagmus. Bring it in, make sure that those eyes cross, perfect. Another one that I can have done is I'm going to make sure that I'm in there, thank you. If I can have you just stand up, sir. Sorry. All right, I'm going to position myself about 2 foot away. I'm going to ask you to cover your left eye with your hand. I'm going to cover my right eye. I'm going to put my hand in the middle between the two of us, and I'm going to ask you to let me know what number you see, and I'm going to assess in each of the quadrants.
2. 1. 1, 2.
Oh.
1, 2.
Perfect. And then I would have him do that with the other eye as well. You can stop. You can sit back down. Thank you very, very much. And that is for cranial nerve 2. For cranial nerve 5, I would ask the patient to clench their teeth. Make sure that I can feel that. And then also sensation of sharp and versus dull. Close your eyes. Tell me if it is sharp. Let you feel. sharp versus dull, okay?
Sharp. Sharp. Dull. Dull. Sharp. Dull.
Perfect. And then if you can let me know which part, I'm just going to rub, and you can just tell me which side and where on your face I'm rubbing.
This side. Up here.
Good, so we also have soft sensation as well. And where? For cranial nerve 7, I would ask you to raise your eyebrows, bring them down and frown, smile, as we had already seen, and then puff out your cheeks. Perfect. They are intact. The cranial nerve 8 would also go along with our ears. Let me know what I am whispering.
1, 2, 3, 4.
Absolutely wonderful. For the cranial nerve 9 and 10, with a tongue depressor, which I do not have, I would ask the patient to please open their mouth and say ah. I would
Ah.
watch for the uvula to be midline, which it is, and then check for that gag reflex as well. While the tongue is still out, I'm going to ask you to move it side to side, up and down. Perfect. And that also checks for the cranial nerve 12. Cranial nerve 11, I'm going to ask you to shrug your shoulders up, push against it, and then push your head that way. Okay, push your head this way. While I am here and I'm already doing this, I can also ask the patient if they can move their head back and forth, side to side, and in a circle, checking our range of motion while I'm there. And then the entire time that I am talking to him and throughout everything, I have been assessing cranial nerves 5, 7, 10, and 12 for voice and articulation with that. Next, I would move on to the neck. I would first inspect it. We start with inspection, make sure that it is symmetrical, that there are no bulges on either side, and then I would come around and I would palpate from one side to the other, make sure that I palpate the carotid pulses. They are good. I would also make note that you do not want to palpate both at the same time for risk of occlusion. Never want to do that. At this time also, we would be doing the lymph nodes while I am here. We would start with our occipital lymph nodes, and then post-auricular, pre-auricular, our tonsillar, our submaxillary, submandibular, submental. These are our anterior cervical, and our posterior cervical. Right in here would be clavicle. I do not feel any enlargement. The lymph nodes, which is, of course, a normal finding. The next thing that I would be working with is the trachea, and looking at that, it does look midline, and you would want to palpate that, and then we come behind your patient and get your tracheal, ask them to swallow, and palpate the thyroid. One of the other things that you would want to do is do your external jugular inspection. However, that is best done while they are lying at a 30 degree reclined position, and so that will be done as well when we do our abdominal assessment. While I am on the back, first thing I'm going to do, normally you would have skin to skin, but for modesty purposes, we are going to leave the shirt on. So what I would be doing is inspecting the back. I'm looking for any kind of lesions, nodes, any sort of moles, or anything that looks abnormal. I do not see anything. The next thing that I'm going to do is I'm going to just do palpation for tenderness, palpate down the spine, any tenderness there. I'm also looking at just general stature, at general posture while he is sitting here. The next thing that I'm doing is I'm just kind of watching, just regular rate of breathing. And then I'm going to come down to the 10th rib space and ask the patient to take a deep breath in. And I am looking at expansion, seeing if it's symmetric, and it is. The next thing I'm going to do is the tactile fremitus, which is I'm going to feel for fremitus in oppositions of the lung fields coming down, making sure that it is symmetric on both sides, and as I move down, it's not any different from the apex to the bases. And so I'm going to ask my patient, every time I move my hands, if you could say 99, that would be great. Go ahead.
99, 99, 99, 99, 99.
Wonderful. Next, I am going to turn my patient. If you can just turn this way so the camera can see your back and see my technique. I would just percuss side to side. Coming down the back. Making sure that I have the same percussion on both sides and that they are symmetric. Next, I would auscultate the lung fields, asking my patient to take a deep breath. Again. And in this position, the t-shirt is making it difficult to hear, so I am going to bring it up. I'm going to warm up my stethoscope for my patient so that it doesn't have to jump out of his skin. Again, please. Wonderful. And of course, we want to make sure that we have good contact with the skin so that we don't have any adventitious sounds due to our stethoscope. The next thing that we would want to do is to do basically the same thing on the front. We would start with inspection. We would be looking for the same kind of things. As we go down, we also just want to feel, make sure that there is no lumps. In women, you may want to do the first initial breast feelings for any nodes or any enlargements that may be there, and come all the way down. Next, you would want to do your tactile fremitus on the front. 99.
99, 99, 99, 99, 99, 99.
All right. And then while you're there, you can also do your expansion. Please take a deep breath. And you are watching for symmetric expansion on both sides. You can also percuss here. You would want to percuss over all of your lung fields as well. And then you can do percussion as well on your cardiac areas. For time constraints, I am not going to do that at this time. But I am going to auscultate over those areas and explain where I am doing at those times. I'm going to do my atrium. Impulse as well. Oh, and those places, I'm sorry, were pulmonic, Herb's Point, tricuspid, and mitral. I'm sorry, I did not say those while I was going down those. While I am here, I would also go ahead and assess all of my pulses. Do my radial, my brachial, we've already done our carotids, one at a time, of course. We can get inguinal when we move on to abdominal later, and you would want to make sure that you did your pedal pulses and your posterior tibial, and you'd want to make sure that you did that on both of them, as well as your popliteal pulses on both. After our chest, we would go ahead and we would have the patient lie down. We would move on to the abdomen. This is also the time that you can have the patient move their head to the side, and you can look for any kind of jugular vein distension for the external jugular and the internal jugular. Next, we would come to the abdomen. The abdomen's a little bit different. What we need to do with that is we inspect, we auscultate next in all quadrants. Sounds. The next thing that we would do is we would percuss in all 4 quadrants. While we were here also, we could percuss the liver. We would start sternum. Down. Take a deep breath for me. We would make sure that we were clavicular, and we're finding those dullness. You would find where the dullness stopped, and you started getting your more resonant sound from your abdomen. You would mark the bottom to the top, and then make sure that the liver was within normal range. For time constraints, I'm not going to do that. I'm just going to verbalize. The next thing that you would do is you would lightly palpate, make sure that there aren't any tenderness, make sure that you are looking at your patient, and then you would do deep palpation. You would palpate for the liver, right in here. You would ask them to take a deep breath, move up, and see if you can palpate the lower borders of the liver. Cannot right in there. The spleen, you can do the same thing, one hand under. You can also have them come onto their side, and you can do I believe it's the grasping test or technique to be able to feel the spleen. You should not be able to feel the spleen. And then also kidneys the same way. I'm going to consult my notes for one moment. one other thing that, while we were here, we would use the bell of the stethoscope, and we would auscultate to try to find the aorta, the renal kidneys, and the inguinal arteries for any bruits. Also, while we were palpating, we would be feeling for any thrills or anything like that. At this time, the abdominal exam would be done, and we could sit the patient up. While the patient's sitting up, I would like to interject that I did forget to show on both the cardiac auscultation and while I was at the carotids, if they are over 50 years old, you would want to use the bell to assess for any bruits within the carotids, and then also listen with the bell in both the lung and the cardiac fields as well, just to be sure that there's no high-pitched sounds that you have missed. I'm going to inspect the arms. I would be checking for musculature. Starting at the shoulders, be looking for symmetry in either side. We've already assessed the muscle strengths at the top. Be coming down. We would do our grip strength. Grip my hands. Perfect. Go ahead and pull against me. Pull down. I'm going to be inspecting my skin all the way down. I've already gotten my pulses. I'm going to be looking at perfusion and color. Good cap refill, 2 seconds. I'm going to ask for range of motion. Just follow my movements. Hands up, fingers in all places, kind of all around, and there is good range of motion. I can have my patient also at the same time, I'm going to stick the foot up here so you can kind of see. I'm going to ask him to pull it back and forward, all around, toes, same way with the knee, back and forth, cross this leg over this leg, and I would ask him to do the same with the others. This time I would also do my reflexes. I would start down here. Here. There we go. And then right here. Hit that notch. Is that right? Oh, there we go. Relax. And then there. Let's put one back here. Relax once more, and I'm trying to show, so I'm kind of on the wrong side to do this. She would come right in this. Relax. Reflexive. Plane right here. And then I would come down to the patellar, right in the notch right in here. And then, oh, and I'm in the wrong spot for the camera. I would do the Achilles and wait for and watch for the reflex down there as well. At this time, I would have the patient stand up. And you can also have them do this while they are laying down. You can assess the hips, have them bring it up, but I can do it just as well standing up as well. If you can put one foot out in front of you, there you go. Bring it back behind you. Perfect. Can you do it with and I would ask him to do it with the other foot as well. I'm going to ask you to bend at the waist sideways. All right. Twist around. Forward. At this time, I can also assess the spine for any kind of scoliosis, for straight, and then back, so you can kind of come back. So there may be a little bit of compression, and that would be another thing that we could talk about within our exam. Romberg would be the next thing that I would do. I'd ask the patient to stand with his feet together, hands to the side, and I would look at if there was any kind of swaying. There is not. Close your eyes. And I would watch for swaying. That's good. All right, you can open your eyes. I'd like you to take your finger from my finger to your nose and back. Good. Do it again. sit down. And just coordination, if you can just take your hands and do what I do.